Dr. Carter, we'll do a quick thank you again so much for joining us. We're thrilled you were able to take time out of your day for this presentation. For those of you who don't know Dr. Carter, he's our Medical Director for Care Coordination and Quality Improvement. He's also the chair of the Department of Our Family Medicine here at Kelsey-Seybold. He has quite an extensive education history before becoming a doctor. He received his degrees in honors biology and chemistry from the University of Illinois at Urbana-Champaign. He also received his MBA from Stanford and then attended Rush Medical College in Chicago. He's been with Kelsey-Seybold quite a while now, and he has lots of experience. So I will go ahead and hand this over to Dr. Carter. So Dr. Carter, thank you again. And you know, we're super excited you're able to join us. So if you have any other background information you'd like to add before you get started, please go ahead and do so.
No, thank you very much. No, you did a great job introducing me, and I will not go any further to emphasize how old and experienced I am. So we're talking about today a couple things. One is capitation, and that's a model of payment, which many of you I think are familiar with, but it kind of distinguishes Kelsey-Seybold a little bit from others in the community, and actually others across the United States. So we'll talk a little bit about how doctors are paid and what different payment methods result in. And I think one in the benefits of capitation, and certainly that's a payment style that we've been very successful with here at Kelsey-Seybold. And then we're also going to talk about care coordination, which is basically trying to get patients, a population of patients, to get the right care at the right time from the right person. So trying to do the right things, not do the wrong things, make sure that patients are getting the care where they're supposed to. So I'll go through that, but first I'm gonna, I think, surprise everybody, because I'm gonna start with something that I'll bet you didn't expect, and it's sort of in honor of the recently departed Alex Trebek from Jeopardy. So if we have any Jeopardy fans, my next slide is one I've been showing the Kelsey-Seybold doctors for about 20 years now, but I thought I would introduce this as a Jeopardy question. So I'm going to try to do my best Alex Trebek voice, and we'll see if you can guess who's the subject of this next slide. This Nobel Prize winning Irish author wrote the play that was the basis for the hit Broadway musical My Fair Lady. Now I know you're all thinking, and I know you're buzzing in as I speak. So as you know, you have to answer in the form of a question. And for those of you who said, who is George Bernard Shaw, you are correct. So here we go. I'm also guessing that no one expected to see this bearded Irish playwright from 100 years ago show up on this presentation. As I said, I've been using this quote for about 20 years. This is actually something that I came across when I was in business school, and I was forced to write a paper on how doctors are paid. And the reason I like this quote so much is I think it gets to the problem, some of the problems at least, with the way most physicians, most medical providers in the US are paid, which is by fee for service. And what George Bernard Shaw said, gosh, almost 110 years ago, is that any sane nation, having observed that you could provide for the supply of bread by giving bakers a pecuniary interest in baking for you, should go on to give a surgeon a pecuniary interest in cutting off your leg, is enough to make one despair of political humanity. And really what I think he's saying is something that we all know, but maybe don't realize how it affects medical care, which is you do what you get paid for. And doctors are no different than everybody else. And first of all, I'm going to apologize by saying doctors and physicians. I basically mean anybody with a medical license who can write an order. So that would include, podiatrists, optometrists, PAs, nurse practitioners, all that. But I'm going to use the term doctors and physicians probably for the most part. And so when I talk to the doctors at Kelsey-Seybold, and I start with this slide, I do say basically what he's saying is that if you need your leg cut off, if you need it cut off, fine, go ahead. But you don't necessarily want the person who makes the decision whether your leg needs to get cut off as seeing that as a financial rewarding thing. It's not that you shouldn't get paid for it, but there is a certain incentive to do what you get paid for. And so nowadays, I will say that cutting off legs is not a particularly lucrative area of medicine. I'm pretty sure it doesn't get done unless it's really needed to, but you can use that statement that Bernard Shaw said, 110 years ago, and talk about other sort of highly paid specialties, even lowly paid specialties like family medicine, which is what I am. And you get to the idea of, well, cardiologists, when they graduate from fellowship, somebody gets up there and says, go forth and let no heart go uncathed. A gastroenterologist, they get up and say, let no orifice go unscoped. And you can go on and on with those sort of things. I will stop with those analogies though. But what we're going to talk about first is the problems with the fee-for-service system and how other forms of payment, particularly capitation, can help with that. So on the theme of you get what you paid for, basically in the fee-for-service system, you don't get paid at all unless you do something as a physician that has a CPT code attached to it. And that typically, in the case of family medicine, it might be an office visit. In the case of a surgeon, it might be doing appendectomies or gallbladder surgery or those sort of things. Cardiologist, heart caths and stents, those sort of things. And basically, the more you do, the more you get paid. It makes sense. Each individual service has a fee attached to it. And if you do more of those, you get paid. Now, as I said, people respond to how they're paid. You get what you pay for. So most patients are paid by fee for service. The result of that is there can be a strong incentive to overutilize. And the reason for that is that certain things that doctors do are basically more profitable than others. So I always give the example, I'm a family doctor. I get paid a perfectly good wage, but when I see patients in the office, if you come in to see me and you might have a cold, if I'm a good doctor, I should be able to diagnose a cold. Most people's mothers can diagnose a cold. Even fathers sometimes can diagnose a cold. So I can pat you on the head, say you have a cold, take some Tylenol, call me if it gets worse. The total charge would be my office fee. Maybe it's $80, $85, something like that. Now, if I felt like it, I could easily order a chest X-ray and a blood count and a throat culture and things like that. And if you need those things, there's ways to tell as I do my exam and talk to you whether they're needed or not. If you need those things, fine. But if I'm just doing it just in general, anybody who comes in with a runny nose, gets a chest X-ray and a blood count and a throat culture, that charge can easily go up into several $100s, and my profit increases. So I'm not blaming doctors that are doing this in this system, but over time, it's been shown over and over again that there is a strong incentive to overutilize in the current fee-for-service system. As I say on this, as you can see on this slide, ancillary income can be very important, particularly for primary care physicians. When it comes to subspecialists that have procedures, their procedural income can be quite important. And the result is sometimes you get more procedures than you really need. So again, not usually cutting off more legs than is needed, but it could be other procedures which are quite lucrative and doctors feel are relatively benign, but in the end they don't help. They increase cost and sometimes they cause complications. So that's kind of what we're trying to, is there a way to pay people that gets around that problem? And the problem has been labeled many years ago, back in the 60s actually, as physician-generated demand. So most of what us doctors do, what we order is discretionary. The example I just gave, me as a primary care physician seeing someone with a cold, I have a lot of discretion as to what I can order. Physicians can and do order more tests, procedures, visits, etc., when they receive financial rewards for doing so. So instead of, again, patting you on the head saying you have a cold, see me if it gets worse, come on back, I might say, well, here's all these tests I want to do, plus I want to see you back. I want to see you back in a couple of days. That's an unnecessary office visit. Probably it won't hurt you, but it probably doesn't help you either unless you're not getting better. The physician is in this case, the physician is an agent of the patient. And in the fee-for-service system, and really in any case when you go to see a physician, you want that doctor to be an honest agent for you. So if you're coming in to see me, you certainly hope that Dr. Carter has my best interest in mind, and he's not going to tell me to do something that I don't need just to line his own pocket. And the example, there's other industries like this as well. And I always say, well, why is a doctor like an auto mechanic? Well, if I go to see if my car is making a funny noise and I take it into the mechanic, I say what it is. I really don't know. So I might think I know something about cars, but believe me, I don't know what's making this noise. And do I want the mechanic who is going to be an honest mechanic and say, oh, well, that's your transmission, but it probably is just that your transmission fluid is low. Let's put in some fluid and that'll probably take care of it. That'll be $40. I'm making this up, obviously. Or do I want the mechanic who says, oh, that looks pretty bad. I think you need a new transmission. Well, I have no idea. All right. Same thing if you're a patient coming in to see a physician. Typically, although there's plenty of information out there, it's hard to figure out what you really need. Do I need an MRI for this headache? Do I need it for a backache? What if it's your child and the doctor says, oh, you need this thing? Sometimes it's hard to say no. So what you want to be sure of, as much as you can, is you want to have a physician who's not incentivized to do things that you don't need. You want to have a doctor who has plenty of incentive to keep you healthy and to do the right things for you, but you really don't want him or her sitting there with a cash register in their head trying to figure out how I can milk you for more money. And a corollary to that is sometimes what looks more expensive is actually cheaper. So I will, again, using the mechanic analogy, if a mechanic, if the $45 an hour mechanic tells you need a new transmission, which is $4,000, let's say, but you really don't, or if it's the $85 an hour mechanic says, oh, you just need a transmission fluid, well, which one's cheaper? In the end, it's the one that's doing the right thing for you. So that's an important point. So I spent our first 8 minutes trashing the fee-for-service system. I do want to say that, it actually works well for the most part. Most providers in the country are paid on a fee-for-service basis. It can't be all bad. And in fact, there are some good things about the fee-for-service payment model. One is that it encourages doctors to work hard. So if you're only making money when you're doing stuff and seeing patients, it encourages you to see more patients. It does encourage you to, work patients in, all that sort of stuff. So it does promote more hours spent in patient care. It probably promotes more patients being seen. Promotes patient access. So if you call in, we'll work you in. It promotes use of new technology. That can be good or bad. So if the new technology is good and it's worth doing in your particular patient, that's a good thing. If it's new technology that doesn't really have any medical advantages over the old, but it's twice as expensive, that's not always good. Fee-for-service medicine tends to sort of, encourage both of those. It promotes development of new drugs. And in a cost-effective, evidence-based environment, we have nothing against new drugs, but we want to make sure we're using them correctly. So if a new drug has an advantage and it's better than an older drug, and you as a particular patient need that advantage, then by all means, we want to prescribe it. On the other hand, if you've been perfectly well controlled on drugs that have been out for a few years or relatively cheap, maybe even generic, and the pharmaceutical representative comes through with a brand new drug, which maybe has some advantages, but for the most part, it's not going to make any difference in your care, but it's going to double or triple or quadruple the price you pay for it. That's probably not going to be very helpful. So development of new drugs is good, but using new drugs in an inappropriate way or non-evidence-based way is typically not what we're looking for. Physicians like fee-for-service because it gives them more freedom. They like we all like to do, what we want to do, and it does provide that. It gives the patients more freedom. Typically, they can go see any doctor they want, and patients like that. Doctors like it because the harder you work, the more money you make, and who doesn't want more money? So, good for those docs. So, what's wrong with the fee-for-service payment model? Well, there are disadvantages for sure. So, overutilization, kind of already talked about that. Things that aren't needed but are still ordered or advised. There's an incentive to provide higher margin services independent of indication. So in the fee-for-service world, just because a certain service is more highly compensated or more profitable doesn't mean it's necessarily more worthwhile. So there's not really a correlation between what something costs or how much margin it provides versus what what it's actually used for. Is it evidence-based for a particular patient? This third bullet point, what is the CPT code for avoiding an admission? So that's an example of, and I'll get to this a little bit later. Typically, when you're talking about, say, an employer who is responsible for the health care of his or her employees, the payer who actually pays the health plan, who in turn pays us, they are typically, they want to save money. They want to provide good care. They want to provide good access. They want their patients to be happy. But if you can do it for 10% less money, that's good. Well, what is the money we're talking about? What is the bottom line? It's the total cost of care. That's what we would say at Kelsey-Seybold, and that's what I'll tell you today. So the price per individual service does not tend to be quite as important as the overall package of care and what the total cost is. So that's where this third bullet point comes from. One of the most expensive things that can happen in the population that you're providing as an employer is an admission to the hospital. Okay, so hospitals are expensive. They are great. We need them. If I need to go into the hospital, I want to have a hospital there to take me. However, if we can work as much as we can to keep people healthy, to find problems before they get bad, to prevent diseases when we can, and the result is we are actually preventing hospitalizations, reducing admissions, or if you're in the hospital, reducing bed days and getting you out of the hospital, that's all great. But when I ask the question, what is the CPT code for avoiding an admission? Because avoiding an admission, an unnecessary admission, is one of the most valuable things you can have. I will wait for the laughter to die down, because that, ladies and gentlemen, is a hilarious joke. What is the CPT code for avoiding an admission? Well, there is no CPT code for avoiding an admission. In fact, physicians in the office, if we want to spend an hour trying to take care of somebody in the office that I could just as easily send to the emergency room, the vast majority of physicians won't do that. They've got a full panel of patients waiting to see them. They don't get paid for that extra service. They send them to the emergency room. I would in that situation. Again, I'm not blaming doctors that are in that situation, but there is no CPT code for avoiding an admission. And I will go one step further. In the fee-for-service system as it's structured today, there's no payment for anything that saves money, for the most part, okay? In the long run, if you take good care of patients, obviously you get paid for taking care of them. But as far as an additional service I can do today that's going to save money, there really is no payment for that. The payment is for me doing more stuff. And if it means I have to send someone to the ER where they can do more stuff, I don't care. So that's the problem we have. And in the bottom, there's another example for it. There's no pay for a phone, email, coordination of care sort of visit. So if somebody calls me on the phone and I handle their issue on just by a phone call, don't get paid for that. That might save an office visit. It might save an emergency room visit or an admission. It's basically free care that I'm providing. They don't get paid for. But in a system that makes sense, in a system where you do reduce total cost of care, those are the sort of things that need to get paid for, at least not be de-incentivized. When I talk to our doctors, sometimes I say, listen, if you're in a fee-for-service environment, doing cost-effective care sometimes shoots yourself in the foot, because what it means is you're not doing unnecessary stuff, and sometimes it's the unnecessary stuff that really makes the money. So I know I sound like a broken record, but that's kind of the problem that we're facing in the U.S. today. And the result is, we spend a lot of money in this country on healthcare, and it is rare to find an authority on healthcare economics who does not cite the adverse incentives of the fee-for-service system as a key ingredient in the disproportionate rise in U.S. health costs. So, what else do we have? So, this is a slide that shows various alternatives to the fee-for-service system. I took a look at the folks who signed up for this. Most of you, I think, are all familiar with these things. And I will start off saying that these things here: pay for coordination of care, pay for performance, shared savings, episode-based payments. Those all have some effect. I am actually not going to talk about them today. The title of the talk was Capitation. Most of you are familiar with these sort of alternative payment models. Kelsey-Seybold, I think, has participated in every single one of these. We continue to participate in some of these, but in the long run, they're not as effective as capitation. So these things over on the right side here, professional capitation and global capitation, is what I want to talk about next. So professional capitation, when we talk about Kelsey-Seybold Clinic, and again, when I talk to our new doctors, I explain to them that actually most of our patients come to us through what are called capitated contracts. And capitation is not fee-for-service. Fee-for-service is where you get paid a certain amount for each individual service that you do. It has to have a CPT code. Professional capitation is where you basically get part of the health plan premium every month. So we get a certain amount per member per month. And we are responsible for all professional services. So the provider group, in this case, Kelsey-Seybold, is financially responsible for all professional fees. And so the professional fees, looking down here, these are things, anything a doctor does, whether it's a Kelsey-Seybold doctor or whether it's anybody else. So if somebody goes to the emergency room, we're the ones paying that emergency room doctor bill. If someone gets admitted to the hospital, they call 911, they go to a hospital where there are no Kelsey-Seybold doctors, we are paying the doctors that take care of those patients. So it's our responsibility. We're at risk for that. We also pay allied health providers, physical therapy, occupational therapy, speech, those sort of things. We pay all the inpatient physicians. We pay the emergency room doctors. We pay for all outpatient lab and imaging. So if one of our patients, again, goes to a non-Kelsey-Seybold facility, they get outpatient imaging, we pay for that. Now, the health plan pays everything else. So the health plan will pay the hospital or facility costs. They pay for pharmacy, so all drugs are paid by the health plan. They pay for DME, which can be cheap stuff like a wrist splint, can be very expensive stuff like a power wheelchair. That the health plan pays that. But an important part of this, and again, this is what I drive home to our doctors, is that in the case of professional capitation, the Kelsey-Seybold Clinic is at financial risk for the professional fees. We have to pay them all. The health plan pays all these, but who is the best person to control these costs? Well, it's the doctors. It's the doctor. It's the providers. It's the folks writing the orders. So even though we are not paying the hospital facility bill, remember the greatest discount is to not be admitted in the first place. Okay, and we are probably the people who are most able to avoid unnecessary admissions. So the amount of work and the infrastructure that we put into keeping people healthy, reaching out to folks that are non-compliant, making sure they got all their preventive care and all that kind of stuff, seeing them in the clinic instead of sending them to the emergency room, all that stuff goes into lower emergency room visits, lower hospital admissions, okay? Even though we're not at risk for that, remember what I said before, what is the actual bottom line? The actual bottom line is total medical costs. So that includes all of this stuff here. So we can, and I'll show you later some very good numbers that show that we do control hospital admissions. We reduce them. And the other thing is we're the ones writing all the prescriptions for drugs. So again, that stuff I talked about before, where we want to prescribe cost effective. If it's the newest, best, more expensive drug, but that's what's indicated, we do prescribe that, but we don't go out of our way to prescribe the newest, latest, most expensive stuff when in fact you can control 90+% of patients quite well on, the older, still more effective, but often generic and quite inexpensive drugs. So we are also the ones, so physicians and our fellow providers, we can have a lot of influence over this amount of cost too. So the philosophy behind Kelsey-Seybold Clinic is that you've got a group of doctors and other providers who are bought into this idea of cost-effective, evidence-based care. We're paid by capitation, so we get a certain amount per member per month. It doesn't do us any good to do a bunch of extra stuff. It does us a lot of good to keep people healthy. So that's, if you remember nothing else about this talk, that's probably what I'd like you to remember, is it helps to have your doctors aligned with what you're trying to do, which is what we call the triple aim of an accountable care organization. It's lowering total medical costs. It is increasing or improving overall quality of care, and increasing or improving patient satisfaction. So capitation, we think, supports all of those aspects of the triple aim. So that's professional capitation, where we get a certain amount per member per month to provide all professional services. What is global capitation? Well, global capitation is basically what your health plan does. They get a certain amount per member per month. That's your health plan premium. And they're responsible for everything, including inpatient and drugs and all that other stuff. In the case of Kelsey-Seybold, we actually do de facto take global capitation, because one of our arms is called Kelsey Care Advantage. It's a Medicare Advantage program, and it's a health plan, and we own that, and so we're responsible for all costs for those patients. And we get paid basically capitation from CMS, from the federal government. And so we are familiar with, trying to do our best as far as controlling hospital costs and also controlling drug costs. But as far as what the doctors do, we treat everybody the same. So that's our philosophy of care. So capitation is great. I can wax on forever. Capitation has been good for us, and many of you on the call today, I think are folks who have been around a long time and have seen the pros and cons of capitation. Capitation can also be bad. So if you're not doing it right, it's easy to go out of business taking capitation. Don't get me wrong. So we've been doing it a long time. I think we know how to do it. There are we're not the only ones in the country, obviously, but a capitated system, I'd say, try not to waste it. We're here, and if you're buying what I'm saying, I think having your patients come to Kelsey is typically going to be a good thing for you overall. So one thing that's different when you take capitation, of course, you get this check every month, which is great. We get paid up front, but we're also responsible for paying for everything. So it's very important for us to have the infrastructure in place to manage that capitation money correctly, just like a health plan would do. And the result is that we have to have a lot of stuff within our clinic that looks a lot like what health plans have. And it's for the same reason. It's try to make sure that what we're doing is right, that our patients are going to the right place, we're paying the right people. We have reasonable contracts with our affiliate providers, those sort of things, just like a health plan would do. So these are all the functions that are within Kelsey-Seybold. And again, one common denominator among all these, not necessarily all of them, but at least these 1, 2, 3, these top 5, is that most physician practices don't have these because they get paid only by fee for service, and they don't have the need for this other infrastructure. So I'm going to go through the next few minutes talking about what these things are, what they do, why we have them at Kelsey-Seybold, and how it helps us manage patients well, and again, manage that capitation check well, so that total cost of care does not go up. So first thing is utilization management, and this is what, when people think of managed care, for better or for worse, this is usually what they're thinking of, particularly doctors. So utilization management is basically where we review high cost services. So the first slide, the George Bernard Shaw slide, when I talk about let no heart go uncath, well, heart catheterization or stenting is an expensive procedure. It's dangerous. You want to make sure it's being used on the right folks. So when somebody wants to do a heart cath, we review it and we make sure that it meets criteria and the patient needs it. Same thing with things like gallbladder surgery or an appendectomy or hysterectomy. Same thing with expensive diagnostic tests. In the case of primary care, I don't do a lot of expensive stuff, but maybe I order an MRI once in a while or a nuclear medicine imaging. Those are fairly expensive, quite a bit more so than a plain X-ray. So we review that stuff. We have the infrastructure in place just like a health plan would to review the to make sure that high cost things are needed. Outside specialist referrals. So at Kelsey, we're fortunate to have a really good group of specialists. Typically, we refer within the group. There's a lot of advantages to that. Medically, we can see what everybody's doing. We trust each other. But sometimes we have to send people outside. We'll review that and make sure that, yes, this patient needs to go to a non-Kelsey specialist. And if so, we want to make sure they're going to the right person. So if you need it, the idea behind utilization management in our case is we want to make sure if you need it, you get it. But if you don't need it, or if there's a better way to do things, we want to make sure you're getting the better way to do things. Case management. So you've probably all heard of the 80-20 rule when it comes to costs of various things. You know, in the case of healthcare, the 80-20 rule, in the case of healthcare costs, it kind of goes with, say, 20% of patients in a population will generate 80% of the cost. They're the sicker patients. It's even more, you know, worse than that. If you want to look at a smaller group, probably less than 5% of patients generate at least 50% of total medical costs. And those very sick patients are ones that really need to be managed well. We want to make sure that they are not falling through the cracks. We want to make sure that they know that they need to come in. If patients, you know, are uncomfortable with their disease, they don't want to come in very often, and often they can be quite sick. We want to make sure we're reaching out to them and getting them in to be seen. If they have to go, you know, for very expensive ongoing medical therapy like dialysis, if they need a transplant, if, you know, they need to go to a non-Kelsey, if they need to go to MD Anderson for something. And we take care of most cancer ourselves, but if we can't do it, or if there's an indication that they need to go to a regional or a national cancer center like MD Anderson, we send them, but we want to make sure we're sending the right patients there. So to manage this fairly small group of quite sick patients, we have case managers, or what we call population health now, which will reach out. We will track those patients. We'll make sure that they have a point of contact at Kelsey, and to make sure, and we kind of track them to make sure they're getting done what they need to have done. This also includes patients hospitalized at outlying hospitals. So if you're driving down the road and you get into a car wreck, or you have a medical emergency, you go to the emergency room, we have case managers who will follow you to make sure that you're getting the care that you need, and eventually, hopefully, you'll come back to Kelsey-Seybold. So this case management is for the sick patients who need the most care and generate the most cost. Don't get me wrong. Sick patients, when we talk about total medical costs, I want to make sure, I do want to make one thing clear. Sick patients are not the problem, okay? We're doctors because we want to take care of sick people. Sick people are why we are here. So taking care of a sick patient, or somebody gets a bad cancer or a bad disease, you know, that's fine. That's what we're here for. What we're trying to do is, as much as we can, keep people from getting sick, for one thing. And two, if they do get sick, make sure they're getting the right care and they're not getting, you know, 5 of the same thing over and over from different providers. So that's what we're looking for. We want them taken care of well, efficiently, in an evidence-based way. And that's what case management's all about. So case management is for individual patients who are quite ill, might need you know, care from multiple areas or multiple facilities. Disease management is actually looking at populations of patients with common illnesses. So classic example is diabetes. So at Kelsey-Seybold, when I say, you know, about 2/3 of our patients come to us through capitated contracts, you're talking about 150,000 patients. So it's a whole lot of patients. Believe me, we have a whole lot of patients with diabetes. We want to make sure that those patients, you know they have diabetes, and that they are coming in at appropriate intervals and getting the testing they need and the follow-up with their doctors. I have been a family medicine doctor now for 35 years, and I'm not telling you anything you don't already know. And when I tell you, some patients don't want to come in, they'll come in for anything other than to talk about their diabetes. So for those patients, and again, you know, that everybody's the same. We all have patients like that in our family. Maybe those are us, those ourselves. None of us probably do everything our doctors tell us to do. So, but we want to, you know, reach out to them. Hey, you're due to have your hemoglobin A1C, you're due to see Dr. Carter, come back in. So we track patients with certain chronic diseases. We identify patients who are out of compliance. So it's looking for folks that are not, you know, doing everything that we want them to do. And then we basically nag them to death to get them in. So letters, emails, phone calls to patients, those sort of things. So we have a very, very active disease management program here. Again, I call it professional nagging. And I know there's a lot of folks on the call today from health plans. Health plans do this too. I will say, I think that we are fortunate. So when I say that I work at Kelsey-Seybold, and you know, many of my friends are health plan medical directors, I always feel like my job is easier, because when we reach out to patients from Kelsey-Seybold, I think patients are more likely to respond. So nothing against Aetna or Cigna or anybody else who's doing this from the health plan side. But when you go to Kelsey-Seybold and your doctor's from Kelsey-Seybold, I always joke that, well, if the phone says Kelsey-Seybold, who knows, it could actually be something important. It could be your doctor calling you. If it's a disease management person, well, darn it, I answered the phone, but they're there for a reason. So I think patients are more likely to read letters from us, to answer the phone when we call, read an email. Our disease management personnel have real-time access to all physician visit notes, tests, and appointments. So if we talk to somebody and we say, hey, your hemoglobin A1C is not very good, and you say, oh, yes, it is, it's fine. Well, we're looking at your record. You can't fool us. I'm joking someone on that. Our disease management personnel function as an agent of the physician. So they're actually employed by the physician group. And doctors do, providers, and you would expect to. We can call patients, so we don't really have to ask permission to call. If you're coming to us as a patient, we have every right to give you a call, and we do. And that includes patients who we call non-PAR. So again, folks on the health plans know what a non-PAR patient is. They're patients who just don't respond to any disease management, and they eventually, non-PAR means non-participating. We still do send them, we still message them. Most of our patients are on what we call My Kelsey Online, which is a internet portal. So we can email them. They get an alert on their Apple Watch or their phone. They get a text when there's a message there. So we have a lot of ways to contact patients. And so again, I feel like our job is a little bit easier than the health plans who are trying to do exactly the same thing and are using the exact same concepts that we are using. But when it comes from the doctor's office, when it comes from Kelsey-Seybold, I think we're probably have a fewer barriers to overcome to get those patients to respond to us. And we're not perfect by any means. Plenty of patients tell us to go fly a kite. So these are the disease management programs that we primarily do. We're working on a couple new ones. We're working on one on for depression. That's a big thing. So we're trying to work on that. We're always trying to look at what the next thing is that we need to work on. But these are the ones that we have now, and these have been up and running for quite some time. Promotion of patient satisfaction. So we want our folks to be happy. Remember, I talked about the triple aim: lower total cost, increased quality of care, and increased patient satisfaction. So promotion of quality and patient satisfaction in the ACO. So one thing I will say is when it comes to quality, I feel like we have a lot of advantages. I like working in a multi-specialty group practice. Okay, Kelsey-Seybold now has about 500 total providers. I like the idea that I'm a part of a group like that. Physicians are directly employed by the group. Again, when I talk to my friends that are health plan medical directors, I'm sure they tear their hair out at night and say, this job would be great if it wasn't for all the doctors that I have to deal with. So, and often in the case of health plans, you're trying to convince people that have no interest in talking to you to do this right thing for the patient. In our case, they're employed by us. I am a department chief. I'm the person who hired the vast majority of our family doctors here. If I need to call one of them, they are likely to answer the phone and at least talk to me in a polite, maybe not overly respectful, but somewhat respectful fashion. So physicians are directly employed by the group, and they are all part of a specialty department. I would say at Kelsey-Seybold, every doctor has a boss. I compare it to Apple Computer. You want to buy a computer from a company that is 5,000 individual people doing what they want and are paid on a piecework basis? Or would you rather have a company where your software programmers and your chip makers and your computer designers have somebody they report to who has specialized knowledge of that? You want to have a car that's built by one guy in his garage. Maybe it's great, but chances are it's not going to be as good as what Ford or GM or Mercedes can do. Same thing with healthcare. Healthcare is not that different. So clinical specialty department structure, every doctor has a boss. We have an advanced electronic medical record, which I love. You'll hear doctors do nothing but complain about the EMR. I go around to all my doctors once a year. I sit down and talk to them for close to an hour. How you doing? Anything we can do for you? What do you think of your nursing, et cetera? I always ask, what do you think of the EMR? Almost everybody says it's a huge advantage. Granted, it can be annoying at sometimes, but I'm now at the 50-50 spot at Kelsey-Seybold in my career. I've been here 26 years. The first 13 years, we had a paper medical record, a paper chart. The last 13 years, we've had Epic, which is our electronic medical record. I would not ever go back to paper. None of us would. And it's a tremendous advantage for all the things I'm talking about. We have integrated disease management and case management, which I talked about. We also have pharmacy incentives to promote evidence-based, cost-effective prescribing. I will throw in there that we basically don't have drug reps coming on site at Kelsey-Seybold. So the old style practice where drug reps would bring in donuts and all that and promote the newest drugs, we really don't have that here. We practice evidence-based prescribing. We do have pharmacy personnel within our clinic. We have pharmacies, as you know. And we do a lot of education. I happen to be the chair of our pharmacy and therapeutics committee, so every month we go through this stuff, but we want to make sure that we're prescribing in an evidence-based, cost-effective way as well. And a multi-specialty group practice gives us the tool to make sure our doctors are doing that. And I will talk in a little bit about the savings that we get from cost-effective prescribing. It's significant, as you might imagine. Promotion of quality and patient satisfaction. First thing is access. People want to have access to their physicians and other providers. So access. There are a couple things about access. One, when I talk about capitation, and this is a key point. If you're a capitated patient, we're getting, the part of the health plan premium. One thing about that deal is that you have to come to Kelsey-Seybold. So you have to see Kelsey-Seybold physicians or other providers. If you need to see someone who's not at Kelsey, and that can happen, we may not have the particular specialist that you need, in which case we'll send you to one of our contracted affiliates, but we direct your care. That is hugely important. And I will say that when I talk about, the bottom line is total medical cost and how important it is, to keep everything, keep your care in a cohesive fashion, you're getting the care that you need. That's a very key point, is that this aspect where you have to come to Kelsey and we have to direct your care, that is absolutely essential. And the example I will give is that, I think I'm a pretty good doctor. I'm pretty sure I'm pretty cost effective. I know I'm evidence-based. I can be the greatest family doctor in the world, do great over years, controlling costs, improving health, doing great patient satisfaction. All it takes is my patient to go to a single specialist who does not buy into that, particularly a specialist that has an expensive service to provide, and that just blows the cost through the ceiling. So if a specialist, if one of my patients goes to somebody else, they do a bunch of stuff, it's very easy to generate a huge amount of cost, and all the work I've done over the years goes away. And in this case, I'm saying, well, if you don't actually need those services. But an example of that would be a cardiologist. You see cardiologists for chest pain. Most chest pain is not your heart. Some is, or some might be. Typically, the first test is a treadmill test. Very simple, been around forever, inexpensive. A lot of cardiologists will go straight to a nuclear medicine treadmill, which is a much more expensive test. Not really any better for most patients. It's better for some, but not for everybody. And it's very open to interpretation. And guess who's interpreting that nuclear medicine treadmill? It's the cardiologist that ordered it. So you've got that agency problem again, where the person making the decisions or advising you is also the one who's making money off which particular decision is made. And physicians have a lot of discretion. So that's the problem with that. So when we talk about so access and capitation, they have to come to us, but we want to make sure we're always available to them. So we have a 24-hour contact center. Obviously, we're open, Monday through Friday, regular business hours. We also have Saturday clinics, but we're also open 24/7 for a nurse advice line. We're also open for video visits and for other type of visits, which are, now that COVID has rolled in, everybody's more familiar with this stuff, and we have a lot of access for that, and patients have loved it. So our 24-hour contact center is where we want everybody to call in ahead. Remember, we would rather take care of you here than have you go to the emergency room. So if your patients call us first, 90+% of the time we can manage you over the phone. We can either give you advice. If you need to talk to a doctor, you can. We can call in a prescription for you. A lot of times patients just need an appointment the next day, which we can do. So that's there 24/7, 365. Promotion of quality and patient satisfaction in the ACO. So again, another thing patients really love is the what's called My Kelsey Online. That's the opportunity that you can always log in on your phone, on your computer, see what your tests are, see what your immunizations have been, see where who you've had visits with. You can communicate with your physicians. You can now see your chart. That's a new feature. You can see the doctor's notes if you want to. There's also employer-specific tools that can be used. So we may have employers who want everybody to get a yearly physical, and they might have a certain form that they want the employees to fill out. We can put that on My Kelsey Online. So specific to those employer groups, you can schedule appointments. Again, smartphone app, very easy to use. Video visits and e-visits. I will tell you, we've had video visits for several years. Not a lot of take up. It's been there. Some of our doctors do them, but a lot of patients were never really, why should I see you on a little bitty phone when I can see you in person? Once COVID hit, we went from, probably less than 2% of our visits were e-visits to over 80% of our visits were e-visits, almost overnight. So that was a huge thing. We were fortunate to be up and running. Again, that's the electronic medical record, for better or worse. It was set up for video visits, so we can do those. Video visits are live, face-to-face visits. E-visits are more like a structured email sort of a thing. You think you have the flu, you can fill out a form, send it in within an hour. We have an answer back for you, and we can, send a prescription in if needed. So patients, it's very happy. Patients love that type of access. So bottom line, what is the bottom line? Bottom line is total cost of care. Kelsey-Seybold capitated plans. And we have shown this over and over again. Most of you are familiar with this. We have been shown to lower total medical costs by 10 to 30% compared with usual care in Houston. It's been validated over at least 2 decades by health plans and independent consultants. And it's been, key. And plus, talking heads like me blathering on, and audiences like you that have that are engaged and do want to learn about this and are interested. That's what makes our business go. And again, before I forget, I want to express my appreciation to you for taking the time to listen to me go on and on here. I'm going to give you a couple of examples here and then a final slide, and then we'll open up for questions. This is a little bit old. This is from plan year 20. Let's see, did I get this? Yeah. So plan year 2013 to 2014. These are example of 2 employers. Employer number 1, very big. They have almost 40,000 patients coming to us. Employer number 2, still quite big. They have over 2,000 patients coming to us. And these are not all their patients come to us, but actually in both these cases, I think most of their patients do. When you look at total medical costs, so this is medical cost, this is prescription cost, and total cost. If what we do is we take the patients from that employer who see Kelsey-Seybold, and we compare them to the patients from that employer who are seeing non-Kelsey-Seybold folks. So if you assume that 1.0 is the total medical cost of the population of patients, and it basically comes out as a per member per month sort of a cost. If that's 1, Kelsey-Seybold's total medical cost is 0.87, a savings of 13%. That's for employer 1. For employer 2, it's even more prominent. Employer number 2, if people non-going to Kelsey-Seybold from that particular employee, if their cost is normalized to 1, Kelsey-Seybold's cost is 0.69, a minus 31%, so 31% savings. On the prescription side, that cost-effective evidence-based prescribing, where we emphasize use of generic drugs when appropriate, 27% savings for employer 1, 48% savings for employer 2. Total cost savings, total medical costs, and again, this includes hospital, obviously includes drugs since we got there, but it's everything. 15% savings on employer 1, 34% savings on employer 2. I talked a little bit before about where does that savings come from and what's the CPT code for avoiding an admission? Well, again, hilarious joke, there is none, but look at what we do. So when we look at same thing. Other is everybody, the same employees who go to everybody but Kelsey-Seybold. Their admission rate 73,000, and this is 73 admissions per 1,000. 73 for others, 55 for Kelsey. Employer number 2, 89 admits per 1,000, non-Kelsey, 51 admits per 1,000 Kelsey. Total bed days per 1,000, 460 versus 274, 605 versus 220. And this is commercial population. Catastrophic claims, high cost claimants. And this is every single employer will show you this. We usually were less than half on the catastrophic claims, 14.1 per 1,000 versus 6.3, 21.7 per 1,000 versus 4.8. And emergency room utilization, again, that 24/7 access, us trying to work patients in instead of sending them to the emergency room, 246 versus 195, 256 versus 238. And finally, this is my last slide. I added this on at the end, so it doesn't look the same as all the rest, but this is one of my favorite slides, and I hope you can see it. This is the Kelsey Care Network plan. So this is Kelsey Care commercial, non-Medicare. Same methodology where 1.0, each of these columns is a particular employer. 1.0 is the average cost, the total cost of care for their patients that go to non-Kelsey physicians. And this is the savings for each employer. So employer number 1, we have 17% of their employees, 19% total cost of care savings. Employer number 2, we have 3/4 of their employees, 21% savings in comparison. Employer number 3, we have 85% of their employees, 33% savings, and you can go on. So the percent of membership is the percent of the total members, which include employees and family members that come to Kelsey. So, you know, this is probably the lowest, 17, but a lot of these are very high, 91%, 76, 48%, 40, 47, 51, 90% there. And you know, there is variability between these groups. Almost all of them show significant savings. This one, I don't know what's wrong with them. I think that may have been a new employer group with us, or maybe in a small employer. But sometimes, you know, sometimes a couple high cost claimants can throw that off. But for the most part, you get the picture on that. So straight average, if you just take each one of these and average them all, it's 29%. If you weight it based on enrollment, it's 22%. So total number seen were total membership represented 63,000. This is from a couple years ago. Again, we have more than that now, but well over 60,000 members. So with that, I am done lecturing you. So I will stop here and ask if we have any questions. I see one. I can. Oh, go ahead.
I was going to say we do have a few questions that came in. One of them was, how can employers help employees better align with their providers to improve engagement?
Yeah, I think the providers can help a lot, and I will give you some examples. So most of our large employers, most employers who come to us through Kelsey Care and maybe have more than 1,000 members coming to us, we do engage them, you know, on a company-to-company basis. We participate. Most of those employers will have like newsletters to their patients. They'll have outreach programs. They might have incentive programs. You know, if you come in for a physical once a year, you will get a certain, you know, benefit from something. And Kelsey-Seybold is very willing and able to participate with that. I'll give you an example. We are able to do employer-specific messaging to employees when you come in for a visit. So when you come to see me, whatever magical thing I do with you, at the end, I will give you some paperwork. This is your after visit summary. It shows what your medicines are. It shows what tests I've ordered, all that. But at the end, there's a place for messaging. And if you are a employee of a certain employer and they want to put a message on that, we can do it. So when you pick it, a Shell employee or whatever comes in and Shell wants us to say something to them about their health, we can put that on there. So we are able to really work, I think, very effectively with employers. We have a lot of flexibility, and we're usually pretty willing to, you know, do whatever it takes. I will say, I think that, you know, Kelsey's a big company. It's important for us to be well run. Our brand name is very important to us. So, you know, we advertise, it's not just Pat Carter with a sign up there on 59, it's Kelsey-Seybold, and people know what we are. And I think that actually helps as well. So having a good, tight relationship between the employer and a group like Kelsey-Seybold, I think patients do pay attention, and I think that's part of our success.
So the next question that came in is referencing the last slide that you put up. So your money slide.
Yes.
Do you know the size range of the employers on that slide?
Yeah, so the range, I will tell you the range of the members that we have for each employer group. I think the smallest one on that side is probably at least 500 patients come to us from that employer. The employer itself, probably most of them have at least 1,000 employees. And the largest is, again, an employer that has close to 40,000 patients coming to us and close to 60,000 patients overall. So it's a broad range. I don't think there's any that are really small with maybe 20 or 30. We have a lot of those as well, but it's hard to, if you've only got a very small number of patients, it's hard to say much about them in a statistical fashion. So we kind of limited it to the bigger employers, but probably at least 500, I would say.
A question came in about wellness and prevention. Are wellness programs, are we seeing an increase in those with employers, or are they sort of going by the wayside and we're seeing some new innovative ways to support employees come in?
I would say, I think most employers are still quite interested in wellness. I'm probably, again, preaching to the choir in this audience, but wellness can be a whole host of things. It can include things like the disease management or health maintenance stuff that we send out at Kelsey. You're due for your colon cancer screening. You're healthy, but you're due for this. You're due for a cholesterol test, those sort of things, which we do sort of automatically. But then employers also will have, we can go to employer work sites to do health fair sort of things, like check cholesterol, check blood pressures. We're usually very happy to send speakers out to employers to talk about diseases, or we talk about COVID, or whatever you want to talk about. We have plenty of expertise here that will do that. And again, the sort of incentive programs that employers have put into place, things like Weight Watchers. We have made partnerships with large employer groups to talk about pre-diabetes. Pre-diabetes is people that are on the edge of diabetes, but they're not there yet. And we have an opportunity to intervene. And it's a wellness program, basically. We reach out, we educate. We have now online pre-diabetes classes that have been quite popular. We have, again, an employer has arranged with us to have free access to Weight Watchers. So Weight Watchers, great program. I don't own stock in it or anything, but I refer to people all the time. But it can be expensive. And that's one of the, people don't want to go there because they have to pay money, but it does help you lose weight. And that's probably, if you want to talk about wellness, that's probably one of the best things you can do. So we do all kinds of stuff like that. And I think employers are still quite interested in wellness. They want to get results. I mean, they don't want to just throw their money away, but I think when they can see, real value and employees getting engaged because of what their employer has done, I think that's a real good thing for employers, and they're still very committed to that, I think.
Awesome. Well, we are quickly approaching 3 o'clock, so we're going to wrap our time up with Dr. Carter today. Dr. Carter, thank you so much for your presentation and for answering some of the questions that came in. If you did, I know we had some other questions that did come in. We will reach out to our sales team and make sure they get those questions answered for you. And if you have any questions about a Kelsey plan, please reach out to your plan representative. You can reach them at 713-442-3456, or you can find more information about Kelsey plans at kelseycare.com. So thank you again, Dr. Carter, and we hope all of you have a wonderful afternoon.
Thank you.